me see if I can maybe get the background a little nicer. Or you know what? I'm not gonna tempt fate. I'll stick with the current background. Okay.
Shall we go ahead, Deb?
Yes, I think we're fine now.
All right. I'll once again introduce Dr. Margolis, who is a board certified physician in neurology and psychiatry. He specializes in the neuropsychiatric care for adults with intellectual and developmental disability in the New York Hudson Valley. He serves as a board member of the American Academy of Developmental Medicine and Dentistry and on the Special Olympics New York Advisory Committee for their Strong Minds program. Welcome, Dr. Margolis.
All right. Okay, all right, just making sure I'm unmuted. Hello, and thank you so much for the opportunity to be able to come and speak with everyone at NYCP. I'm really honored to be included as a speaker among such distinguished colleagues as have already spoken this morning. So like I said, I'm Ben, like we said, I'm Ben Margolis, a neuropsychiatrist in the Hudson Valley. And so today I'll start with my favorite imaginary posthumous quote by a hero. I always like to start with a photograph of one of my heroes. This is Dr. Leo Kanner, the first American child psychiatrist and a pioneer in the definition of and identification of and treatment of autism. And of course, I just feel everybody should get their COVID vaccine. So let's see. Okay, so no disclosures. So what we'll be talking about today, first, I just want to mention there are some CME considerations. So anytime there are CMA consideration, there's CME content in the talk that I'm giving, I'm going to point that out and it'll be indicated in red. So what this talk is, I'll first say what this talk is and what it isn't. What I'd like to share is not necessarily a talk about general psychiatry or psychiatry in autism and IDD as far as detailed descriptions of treatments in individual disorders. That really is a separate set of lectures. What I'd like to provide today is a description of where we are, what we face as behavioral health providers, psychiatrists, mid-levels, when we're working with IDD, to be able to provide you with an understanding of how we think about medication management. And my hope is that this will be useful for clinicians who work in other fields so that they can understand what decision-making trees we're using and to understand how we consider diagnostic overshadowing, when to start a medication, so that we can better collaborate and we can give you the information you need to be able to team up in care, and that we can receive the information we need to be able to confidently and safely prescribe medications going forward. So ideally, at the end of this talk, we'll be in a better position to understand each other better and collaborate better. And if any of the audience actually are psychiatrists or behavioral healthcare providers, I'm hopeful that there may be some pearls inside that can help all of us work better in terms of best practices. There are many talks like this, but it still is absolutely valuable because prescribing data shows that these talks are still needed. So please do stay tuned. Let's see. So first I'll talk about where we are. Then I'm going to talk about the fundamental issue in providing psychiatric and behavioral care for individuals with the IDD, which is, are we managing behavior or are we providing true psychiatric care? And so I'll talk to you about how we go about making that determination. And I'm going to go in a lot more detail about diagnostic overshadowing. Dr. Holder this morning described it beautifully, and I'm going to go into much more detail about what our collective challenge in my field is. Then I'm going to provide what I feel is a best practice model and template for what best practices are going to be going forward with an interdisciplinary collaborative model, and some suggestions about how we can implement that going forward, even before the next generation of providers that learn from the NCIDM projects and from clinics that are being built can provide. So what we can do now, I'm going to give some examples with some of the most commonly seen syndromes we see in our clinics, to give examples of some of the potential pitfalls and extra considerations we need to make when we provide care. And then I'm going to talk about some of the tasks ahead with some just real concrete things that maybe we can do to make a difference starting today. So let's see. So where we are. So it seems like that we as psychiatric providers, all we have is this hammer of medications, and that everything to us looks like a nail. If you go by public health prescribing data, given the number of psychotropic medications that individuals with IDD are being prescribed. But then again, challenging behaviors are very common among persons with IDD, and we are managing some really difficult problems together as a team and as caregivers. And so there is value in the care we provide. We are not as a field dedicated to anything except improving the quality of life for the individuals we serve. So it's a matter of aligning our goals and making sure that we practice safely. So forgive me if I'm preaching to the choir, but here's some evidence of why this seemingly obvious message is still needed. So prescribing, these are three of the most recent examples going back to 2013, but we have 30 years of data showing that about half of the individuals that we serve are prescribed psychotropic medications, primarily antipsychotics, historically, and only about half of those are actually diagnosed with a psychiatric illness. So I'm not sure. So does that mean we're prescribing for just behavior? Yes and no, but just three examples. So this does not just bore out in the US. This is also true in Canada and UK. In Ontario, 2018, large study of, I didn't put in the number, but large study of adults in group homes showed that 40% of all adults with, of adults with IDD, not just in group homes, but almost 40% of all adults with IDD were prescribed antipsychotic medications, and 56% of all adults with IDD in group homes were prescribed antipsychotics. And again, about 30% of those had no psychiatric diagnoses. 2015, among primary care settings in UK, almost 50% of adults with IDD had a record of being prescribed antipsychotics for challenging behaviors. And then here at home in New York State, Tsirius did a review showing that 4,069 adults, among the adults he looked at, 60% received one or more psychotropics. 45% of those 4,069, not 45% of the 58%, but 45% absolute, were treated with antipsychotics, and only 50% of those were for psychiatric diagnoses. So, as a rule of thumb, again, you can think that about half of the patients with IDD we see are going to be treated with psychotropic medications as we inherit their care, and about half of those have been formally diagnosed with a psychiatric illness. And attempts to change that have not yielded significant changes over the past 10 years. The example in Glasgow was a prospective cohort of, I think it was a smaller study of less than 5,000 individuals. But they found that as of 2020, most people are not weaned from medications once they're started, as we all see together snowballing of medication regimens. Polypharmacy is a problem, and medications continue to be added when problematic behaviors continue. All right, so what does this mean? Are we prescribing inappropriately? In some cases, yes. And I'm going to point out some things at the very end of the talk that we can do to address this right away. Thankfully, and I use this word very deliberately, the heroic work by the people at AADMD, by people like Dr. Holder, Dr. Sayasoko in NCIDM and at AADMD in addressing these problems with education. And those problems that I'm referring to, of course, diagnostic overshadowing, managing behavior with medications, the problem of the fact that for many of us without cultural competency in education, everything can look like a nail. And then simple cultural competency can address this. But in some cases, no, we do have limited data. EMRs don't share education. Diagnosis of IDD is missing in a great number of charts. So our ability to accurately gauge what medications are being prescribed for is limited. So the other problem is that we're working primarily in off-label territory. So diagnostic accuracy is challenging in the setting of medical complexity, but also when we may be prescribing off-label, the link between a diagnosis and a treatment may be lost in record. So in some cases, no, it's a complex problem. But the problem is also that when we're working off-label, we have limited agents available. Again, this is in red for a CME consideration. We only have 2 FDA-approved agents. Risperidone approved in 2005 and aripiprazole approved in 2009 for autism-related aggressions and compulsions. So everything else is off-label. And we know we have 50 years of history in the patients we're working with. How many people are prescribed first-generation antipsychotics, neuroleptics, phenothiazines, off-label for these same problems? So the good news, though, is that many mood, anxiety, and occasionally thought disorders are co-occurring and do have on-label treatments. So it's not like these roads are totally unmapped. We can, if we're careful, very reasonably diagnose and use first-line FDA-approved treatments for co-occurring disorders. So before I discuss on-label treatments for co-occurring diagnoses, I do think it's worthwhile, and it's worthwhile to review at it's absolute fundamental. It's our fundamentals. Diagnostic overshadowing. So defining diagnostic overshadowing, as Dr. Holder said so beautifully before, it's attributing medical issue or an alternative problem to psychiatric illness or to a developmental disability itself, which can lead to dismissing real medical illness. So we can all get fooled even though we're careful. I'm going to give a case example later, but reassessment is always necessary. And again, I know I'm preaching to the choir. I know this audience is likely to know this, but it still warrants review because all of us can get fooled. So again, is a behavior a psychiatric symptom, or is it an expression of an alternative problem? So I just want to point out that even us, even the audience here who's so familiar with this problem is still at risk of diagnostic overshadowing because of the fact that we are working as part of a team where some of the clinicians that we rely upon in the community may have limited cultural competency and limited experience working with people with developmental disabilities. So people in the community who are busy with limited familiarity, no matter how much they care, they are going to be at the highest risk of missing a problem. So it's really helpful to know the other docs caring for an individual. I had a potentially life-saving catch because I did a physical exam on an individual that had been sent back to me by a busy primary care doc who said, no, this is entirely behavioral. This is a developmental disability. Where a person had in that case, a pericarditis. Which led to tamponade. So knowing the other docs caring for an individual can be really, really important. Let's see. So the most common, I'll review here, even though we all know this, the most common medical issues masquerading as mental illness are going to be pain, constipation, as was so beautifully really fleshed out in the first lecture, oral health and dental pain, as Dr. Sayasoko talked about, UTIs or infections, medication and side effects, and iatrogenic issues are always possible and unfortunately very common. So we need to make sure we have accurate medication lists. In addition to seizures, we can't miss seizures. So the other risk, which I think is potentially separate from diagnostic overshadowing, but simply a matter of misunderstanding, is the issue of potentially misunderstanding a behavior. That's a separate risk. We shouldn't prescribe Zyprexa to treat a disagreement with a housemate. It's easy to think that because a behavior or a problem can be really extreme, and because we're dealing with severe aggressions and severe behaviors sometimes, that it must represent a psychiatric illness. It must represent something that needs medication. And yet asking more questions, maybe these problems never happen at program, but only start happening when somebody comes home, and only happens when a roommate comes home in the example above. Does that mean somebody has bipolar disorder? Potentially so. If we get a patient that's in our office that we have a limited history on, because the only person providing history is maybe the individual themselves, that that sometimes may have challenges communicating the full scope of a problem, and maybe they're with a staff member that only sees that individual for a limited period of time. We may misdiagnose a problem simply by not realizing that it's only happening in a specific context. So we can't let ourselves run the risk of misunderstanding a behavior. That's a separate risk, I think, from diagnostic overshadowing. And then, of course, it always should be said, and I know it's said in every one of the lectures like this one that's given, but we have to hammer, because sometimes it's very uncomfortable to ask about, we have to screen for abuse and PTSD. It's hard. It's hard to talk about sometimes, but the individuals that we're caring for are vulnerable, and abuse does happen. PTSD is an underrespected and undertreated illness or disorder among our patients, especially those for whom we may have limited histories, who have been in ICF or institutional settings, or those who have faced additional challenges of socioeconomic status. It's important to screen for these things. So just a quick example. I was thinking about an article that's going to be published that was sent out this past week by another hero of the field that I always like to acknowledge, Dr. Rick Rader, who wrote a beautiful article about the value of friendship. And it made me think of a case just in the past couple months that I saw of a case example of misinterpretation of behavior. So a patient of mine, a 64-year-old man with mild IDD and MDD, subthreshold PTSD, who had some significant challenges related to SES growing up, long history of reactive depressive symptoms, and reported suicidal ideation when he felt lonely. His depressive symptoms were well managed with sertraline and mirtazapine, but when things were challenging, he would report SI, and his caregivers in a host home setting would always call 911. When he did report suicidal ideation, he would say he had a plan to starve himself, but he would eat if he didn't have to be lonely, and if he could work with his caregiving team. So during the pandemic, unfortunately, his loneliness and isolation worsened. He really, an ex-girlfriend moved away. His favorite bus driver retired. And then, of course, as we saw, so many of us saw during this period, services were interrupted. ComHab services were reduced first due to closure. And then there were critical staffing shortages that prevented him from being able to connect with other people. Started having more frequent complaints of SI. And then a family member potentially was moving out of state. He reported SI and went to a local ER. I learned this after his discharge, and he was actually admitted psychiatrically, diagnosed with bipolar 1, started on risperidone and lithium, and there was no, I have still no history of mania. Although if hospitalization is a requirement for the diagnosis of bipolar 1, simply by hospitalizing them, they could have said he met one of the criteria. But I felt it was a soft call. And on discharge, he was fatigued and had profound tremor and Parkinsonism. On follow-up interview, his SI, he reported, had melted away after meeting a new girlfriend he could correspond with via postcard. Friendships matter. And he no longer complained of mood symptoms. His regimen was consolidated. I was able to taper the risperidone, and we stopped the lithium right away. He's thriving with additional social supports. So the point is, listen to our individuals. It's easy to misunderstand or misattribute behavior to a psychiatric illness, and it still happens. And these are not necessarily complicated things, but require a certain degree of cultural competency and additional ancillary information that either I could have provided or the people who knew him could have provided. But the individual himself, in the setting of being upset, may not be able to provide with us the complete picture. So I feel like this was an issue of misinterpretation of behavior and cultural competency. Best practice, what I'm talking about is working collaboratively is the most important thing. So for those of us in the audience who are not behavioral clinicians have the psychiatrist's cell phone number that you're working with, that's working with the individuals. If we're in different systems, find a way to speak to us. I try to do the same. Working collaboratively is going to be so important. But working collaboratively doesn't just mean within our fields. It means working collaboratively with the team, working with individuals. And it's really simple. This is low-hanging fruit, just like Dr. Holder said at the beginning. These are not hard changes to make, but they can make an enormous difference. Doing things like ensuring an accurate medication list, that's a particular pet peeve of mine, so I put it separately, but as part of an accurate overall accurate medical history is going to be really important. So with the example before, or with the example I gave us, we need input from the individual we're working with. That's the most important thing. And I don't need to remind the individuals. The providers and the team who are taking time out to attend this conference. That's going to seem obvious to all of us, but we can share that message with our colleagues. So input from the individual is going to be the most important thing. Nursing staff is so important in congregate settings because we can't rely on non-medically trained direct care staff to provide detailed medical information. So we need to be able to access the nursing staff in congregate settings. And that is one of the easiest, well, maybe not easiest, but one of the simplest things we can do to avoid diagnostic overshadowing. Outside of congregate settings, we need information from family members or staff members who know an individual best, their behavioral team, staff psychologists, the behavioral clinicians in a day program staff, the behavioral clinicians working for an agency, we need to be able to speak to. We need to be able to, of course, like I said at the beginning, collaborate and converse with our other medical providers. And we need objective data. We cannot rely on the subjective report of somebody who comes and says, I think maybe I'm better, and the staff working with them or the family says, yeah, I think they're better, it's okay. That isn't a way to follow improvement except with subjective mood symptoms, but we need more. There is value in that, of course. We can't skip the value of someone's subjective experience, but we need sleep data, we need bowel charts, we need objective behavior data. So and with that, teaming up and providing this education of what we need to direct care staff when they come and work with us, to the team at an agency when they're working with us, to other providers, can help make a great dent at the very least among our patient panels. And then of course, we need baseline health and behavior information. So of course, I say again, an accurate and complete medical history is going to be needed. This is a lot. So I'm talking about needing a lot of information to be able to understand a problem. Yes. So information gathering may be needed at more than one visit. We can split visits and say, I don't know, we're out of time. Let me reschedule next week. Let's get you back in so we can understand. And next time, bring this person with you, bring the number of this person, let's collaborate. Telemedicine can make that much easier because we can, during a visit, have staff call in, have a nursing staff call in, have someone join on Zoom while the person is there. We can hybridize visits. We have a lot more resources to be able to collaborate now that we have permission for telemedicine. Also, reimbursement for our time is possible. At our clinic, we bill for complex care. Medicare, Medicaid covers it. Not all private insurances, but if you want to contact me afterward, I'll give a link. Our time can be reimbursed for calling an outside provider at the end of the day. It's not, of course, it's not wasted time, but it may not be donated time. We may be rightfully reimbursed for the extra work that we do to provide care. So let's say we've done all of this work and we have collaborated care. We've ruled out any kind of medication, medical contribution. We really feel that there is a diagnosis. What are some of the most common diagnoses we'll see? Just want to talk about, in addition to autism in IDD, the on-label, I should say, the co-occurring diagnoses we'll see with accompanying on-label pharmacotherapy and first-line, very reasonable treatments are going to be anxiety spectrum disorders, very common along with autism, common in general among the general population, and certainly seen with IDD, given the psychosocial stressors that go with being an individual living with IDD. Generalized anxiety disorder, panic disorder, very commonly accompanies autism, and panic episodes can present with rages and aggression, and may be anxiety spectrum versus intermittent explosive disorder. OCD, which is going to be among the most commonly co-occurring disorders in autism. Repetitive behaviors is part of autism, and sometimes it can be a problem on its own, really getting in the way of functioning and impairing the quality of someone's life, and we can help with that. PTSD, of course, I mentioned before, anxiety spectrum disorder that has both psychotherapeutic and medication treatments. Again, for the anxiety spectrum disorders, SSRIs are still first-line, TCAs are second-line treatments. There are SGAs. When I say SSRI, by the way, of course, I'm referring to selective serotonin reuptake inhibitors, TCAs, tricyclic antidepressants, and SGA, I'm talking about second-generation antipsychotics like Abilify and Zyprexa, both of which are FDA approved for depression, which I'll mention in a moment. Like these other mood disorders, some of the other mood disorders, we do see bipolar 1 and 2 disorder. We'll treat those with mood stabilizers. Again, there are additional caveats that we consider because of the fact that we're working with medical complexity in IDD. We see major depressive disorder, again, like I mentioned before, treated with an SSRI or an SGA, in addition, of course, to adapted psychotherapy and to behavioral and environmental supports. And never to discount, like this first case, adjustment disorder and reactions, environmental changes and transitions need to be respected. But the point of all of this is that there are on-label therapies for these as first-line treatments. And if we're careful with our diagnoses, considering working collaboratively, we can make accurate diagnoses together. One of the things I want to mention is how many of our patients, I'll just ask kind of rhetorically, how many of our patients do we see that were diagnosed with schizophrenia when they're nonverbal and have profound IDD? I don't know how people come to that diagnosis. We need to, as a field, be cautious when we're diagnosing thought disorders. Hallucinations do not always portend schizophrenia or a psychotic disorder. A thought disorder is perhaps overdiagnosed, or specifically schizophrenia and schizoaffective disorder are perhaps overdiagnosed in the population we serve. Complex or multimodal hallucinations, anytime they're reported. When I say complex or multimodal, I'm talking about hallucinations that occur in more than one modality, more than one sensory modality. I see someone, I hear them, they're in my room, I'm talking to them. That's very unusual for a thought disorder. That's very common in complex PTSD. It's very common as an expression of a complex fantasy or trauma, or somebody with an imaginary friend. I was thinking about one example of a person that came to me with a diagnosis of schizoaffective disorder because they had FRAGILEX and they were very much into wrestling, and they would act out really complex scenarios where they were fighting zombies with their favorite wrestler. Sometimes they'd get angry. They would act them out and throw pillows as part of it. I said, "Is that what the diagnosis was?" And they had historically been diagnosed with that. I'm not sure where that came from. That's an issue of cultural competency. So that is not schizophrenia. Are these episodes accompanied by periodicity related to seizures? Is there periictal, either before or after a seizure, psychosis and confusion, delusional thoughts, obsessive thoughts associated with seizures? Is there a delirium or toxic metabolic encephalopathy? The most common thing you'll see on a geriatric unit, I feel like, is somebody who's suddenly confused, picking at things, seeing things, and it turns out they have a UTI. Why wouldn't we have the same consideration for the individuals we're working with? Making sure, visual hallucinations can commonly just be a representation can be a symptom of, cataract with the cortical release syndrome, something called Charles-Bonnet syndrome, very well described. Hearing loss can present with some visual auditory hallucinations with a similar cortical release phenomenon. So be very careful when we're asking about sensory changes or hallucinations. But that's not to say that it doesn't exist. We just need to be careful about them. Persistent delusions and ideas of reference happen. Auditory hallucinations creating distress along with delusional beliefs may represent a true thought disorder. It does happen, and schizophrenia is a phenotypic diagnosis and may be seen, but is also very treatable among the individuals we serve. Also, of course, remember, this is low-hanging fruit. Olfactory or gustatory hallucinations more commonly are going to be ictal, related to seizures. Tactile hallucinations are most commonly seen in encephalopathy or medication withdrawal or substance withdrawal. So I talked about, I'm not giving a lecture specifically about what diagnoses we'll make. It's more of a template, but what resources might a clinician want to use? They are out there. So wonderful resource from our colleagues at the National Association for the Dually Diagnosed, which is actually located near me in Kingston. A fantastic resource, the DMID2, which is an adapted DSM. There's a workbook associated with it, reasonably priced. I recommend it be on the shelf of any of us providers. In addition, specifically a manual that has some really practical guidelines for clinicians and psychiatrists, mid-levels who are working with people with intellectual disability. Is a Psychiatry of Intellectual Disability, wonderful practical manual by Dr. Gentile. So there are resources out there. Those are just a few. So let's say, again, we've got all our information. I want to just talk about what best practices are. And these are, of course, best practices anywhere among the general population, but I have to emphasize them again because we're not necessarily doing it. But of course, every medication we prescribe should have an associated diagnosis or a clear indication. So the baseline information we need is going to be so important to get before we start, because again, the individuals we're working with and we're serving may have limited ability to provide this information themselves, but we need to team up with families and agencies to be able to get baseline before we start blood work and serum studies. Many of the syndromes we work with or we're treating have associated blood dyscrasias that are not attributed to medication. Many medications we work with cause granulocytopenia, thrombocytopenia. We need to be able to know where we start, in addition to, of course, tracking lipids with antipsychotics, making sure we're not putting our patients at risk for diabetes. EKGs are going to be really important. We're working with medications that prolong QT. And also baseline information. How can we gauge improvement if we don't have information to start with about our sleep habits, about weight, bowel habits, and appetite? As was mentioned before, we're in the earlier lecture. Great point. We're not going to necessarily start an anticholinergic medication that could contribute to constipation if someone at baseline is having a bowel movement once every 5 days and has a very, very limited diet. We're going to want to address those things, or very carefully adjust our medication or prescribe our medication regimen in light of that. Does somebody have a history of an SBO or earliest? What does someone eat at baseline? And also, of course, we want to have a baseline gait and swallowing assessment. Many medications can affect gait. Many of the challenges we're treating in the beginning are associated with gait instability. We need to know where we're starting. Swallowing assessment is going to be so important. Antimuscarinic agents are going to potentially increase saliva production, have sialorrhea associated if someone has baseline swallowing dysfunction. Xerostomia and dry mouth are associated with serotonergic agents or anticholinergic, antinicotinic agents. So we're gonna need to know where we're starting. In addition to the bulbar Parkinsonism that can just come independent of sialorrhea with our medications. So, of course, as well as a best practice in general, this is almost like a tautology. Use non-pharmacologic tools whenever possible. Environmental and behavioral supports are a true first-line treatment for anxiety spectrum disorders and most sleep disorders. Supports but there are some challenges which absolutely very clearly require medications and require psychotropic medications, and we have been able to make tremendous a tremendous impact and provide great benefit to the individuals we serve carefully with them. But when we do need them, we want to use them in low doses if possible, minimally because of associated risk, and in conjunction with these other supports. So again, I want to talk about some pitfalls that we need to keep in mind as prescribers. That it can feel like an emergency when somebody comes into our office, and the behaviors we see may, when we're not familiar with working with these teams, may seem very extreme and may seem like an emergency. And the instinct of many people is to make an assumption that a high dose of medication must be needed because of how significant and severe the behaviors are. But we have to back up and take our own pulse and remember that we dose a medication and treat an individual rather than the severity of the behavior. So start low and go slow. Reassess a current regimen before adding a new medication. You don't want to have two different medications of the same class, of two different classes, maybe treating the same disorder at maybe both at low or medium dosing, when we may have been able to avoid another medication altogether by just titrating the first. Or reassessing to avoid using multiple medications in the same class. So again, just to emphasize, like I say in this slide, dose medications to the person conservatively rather than to the degree of behavior. Someone may do just fine on 0.5 milligrams of Risperdal for a compulsion that may lead to really significant behaviors, and there's no need to assume that they'll need 6 milligrams of Risperdal because of that. Give adequate time to reassess for benefit before titrating. It can feel like an emergency, so many clinicians might want to increase a dose very, very quickly to get to a therapeutic dose, but you can't really tell what a therapeutic dose is until you give it time. So let something reach steady state, gather some data and observe. Really give something time to be able to benefit. Different classes of medicines take different time, take different amounts of time to be able to reassess. So also avoiding pitfalls. It may be a clinician's instinct to say, whoa, this person is on so many medications, I've just inherited their care. Let's take away this, let's take away this, let's take away this. You don't need any of this. I would really caution my colleagues to be careful before tapering or especially discontinuing a medication. SSRI discontinuation can be very uncomfortable. People can be delirious and have visual hallucinations and rebound anxiety just from discontinuing an SSRI, like Paxil is the most extreme example, but SNRIs, you can have brain zaps, so that would be like venlafaxine or Cymbalta, duloxetine, uncomfortable brain zaps from discontinuing those medications. Clozapine needs to be tapered. You don't want to have a reactive dysautonomia with temperature dysregulation and cardiac dysrhythmia. Mood stabilizing AED, I mean anti-epileptic drug. So a mood stabilizing AED might be discontinued because you don't think the person needs Depakote anymore, but you may realize you are unmasking epilepsy that you didn't realize you were treating. It's very common that over the years, as care has transitioned, a psychiatrist may take over an epileptic drug regimen, thinking it's for just for behavior, and not realizing that historically it has been a very effective AED for the person. So be cautious about discontinuing or tapering even mood stabilizing AEDs without all of the information we need. Rapid discontinuation of neuroleptics. So if someone is on neuroleptic, I mean an antipsychotic, dopamine blocking medication, phenothiazines, if you suddenly discontinue those medications or rapidly taper them, you can unleash a withdrawal dyskinesia that is identical to a tardive dyskinesia, but from rapid discontinuation rather than from years of being on the medication. Abilify seems to be, or aripiprazole seems to be a significant risk for that. Or you can unmask as well withdrawal akathisia, I should say, sorry. Akathisia, which is an inner sense of discomfort and unrest, an inner anxiety preventing somebody from being able to sit still, that's described as being terribly uncomfortable, and it's awful to see. So avoid pitfalls with tapering too quickly. Of course, we're going to avoid multiple drugs in the same class unless unavoidable. So this is the one of the CME things that I was pointing out. Note this for the CME questions. So monitoring for iatrogenic risks and side effects is especially important in IDD for exactly the reason I said earlier. So this is just a review of what we covered earlier. Paralytic ileus is a risk. Look for bowel obstructions or ileus. Can be potentially fatal. Of course, clozapine is the most significant, being so anticholinergic, but SGAs are under-respected for their potential. Again, they do have great benefit, but they also have risk. So medications like Zyprexa, risperidone, Seroquel, seemingly relatively benign SGA, can cause an ileus, and we have to watch for these things. Sorry, I misspelled. Anticholinergics, not antocholinergics. But anyway, watching for hyponatremia. So you can have a chronic hyponatremia that you'll see commonly in the combination of an SSRI and Tegretol or carbamazepine, or from an SSRI or serotonergic, really any serotonergic agent like a tricyclic antidepressant. You can see hyponatremia, and someone can do just fine and not necessarily have any symptoms, which would be potentially seizure for acute hyponatremia, or gait changes, confusion for mild, for more chronic hyponatremia. But pain or the addition of another medication can lead to acute on chronic hyponatremia, which can be significant. Monitor for that regularly with SSRIs. Granulocytopenia. So obviously the most well-known example would be clozapine, which requires a REMS. For those who are unfamiliar, clozapine is an atypical antipsychotic, which is very, very effective, also for mood stabilization, but requires a blood draw every week for the first 6 months, every 2 weeks thereafter, and then every month indefinitely to monitor for granulocytopenia. But it's not the only one. Any antipsychotic neuroleptic dopamine blocking medication, second generation or first generation neuroleptic, can cause granulocytopenia. Tegretol, carbamazepine, which we use for mood stabilization off-label commonly, or for excellent seizure control in some patients. QT prolongation, we need to monitor. Any of our medications can contribute to QT prolongation, so making sure we have serial EKGs, especially in older individuals where they're on more medications. Xerostomia, dry mouth with serotonergic agents, as Dr. Sayasoko talked about in more detail earlier. Gait changes we talked about with almost any AED or neuroleptic. Neuroleptics, you can see them with Parkinsonism, but also gait changes with hyponatremia, with AEDs, with Depakote, independent of or accompanying hyperammonemia. Dyskinesias and dystonias, of course, we monitor for with any neuroleptic. So that's the CME. You definitely want to know that all of these things can happen. So here's an example where, I pay attention to all these things, and I think maybe I'm potentially immune to them, but I'm not. All of us are. Here's an example of a patient, of how patients can have multiple and complex problems, even when following best practices. I have a 59-year-old woman that I was treating. She has moderate to severe IDD. I don't have any neuropsychological test results, but hoarding behaviors, aggressive behavior, and skin picking, a lot of anxiety. Transitioned from living with a family member into a group home, and had a very difficult time with the transition, wasn't coming out of a room, wasn't functioning, was hoarding trash, skin picking, and aggressive. Started an SSRI with titrating, did pretty well along with behavioral supports, stabilized on Prozac. And then another transition had to happen. She moved to a different agency to be closer with the family member when that family member was transitioning to end-of-life care. So our patient, I saw all these things happening. I coordinated with her primary care doctor at an Article 28 clinic and her behavioral team. I didn't have any evidence of anything else going on, but things kept getting worse. It seemed reactive, all the data I had, and then talking to her, she said she didn't feel great, she felt sad. And denied any somatic complaints, but just didn't feel herself. We added risperidone. she seemed to do well, but then started getting fatigued. I pulled away the risperidone, stopped the risperidone. Limited response, still stayed fatigued, and yielded 2 hospital admissions, leading to a diagnosis of endocarditis with a chronic vegetation, meaning that the vegetation was there for a while when I was titrating the risperidone. And the take-home message is that even with vigilance, we can still miss things. The endocarditis is classically very difficult to diagnose, especially because she didn't declare herself with fever, and the symptoms can be very protean. But the point is that we need to stay vigilant. Reassessment is always required. So what I'm going to talk about now with the remaining time is some syndromic examples of the most common things that we see that add, or that I see in clinic, that add to the medical complexity, that may be that are just examples. Certainly, it's not complete, obviously. I mentioned Tourette here. Although Tourette is a phenotypic diagnosis, there are some genetic links, but it's not a genetic diagnosis. I include it here because it's something I very much love to treat. And it's very helpful in identifying in the community. And I'll give an example of why. Because it is seen in individual. Of course, some of my patients with Tourette are CEOs or neuroscientists, but it is seen among our patients with IDD and autism, and can help provide some on-label guidance, and can help us keep track of and associate some of the clustering symptoms we see with Tourette. So, and the picture here is of Dr. Gilles de la Tourette. If anybody has time, the syndrome was named by Dr. Charcot, his professor, when he was an intern. It's an amazing life story, quite tragic, but worth a read if anybody has time to look up Dr. Tourette's life story. So Tourette syndrome is diagnosed by the presence of the key is multiple motor tics with at least one vocal tic, and it's very commonly attributed to just stereotypies or self-stimming behaviors. But we do see motor tics and vocal tics among the patients that we're working with autism. In Tourette, tics are going to wax and wane. There's very often a familial component independent of IDD. And then the things that kind of orbit the tics are going to be anxiety spectrum symptoms, OCD, obsessive thoughts, sometimes rage attacks, panic, intermittent explosive disorder like rage attacks, and then ADHD. And it may, again, I said it may be present with autism or IDD. Again, for the CME, because I'm pointing all that out. So first and second generation antipsychotics are both first-line treatments for the motor tics associated with Tourette. So historically, classically, we would use Haldol or Orap, Pimozide, haloperidol or Pimozide generically, and Prolixin or flufenazine tended to be better tolerated, again, specifically for the motor tics, but also can help with some of the compulsions and compulsive thoughts. And then later, second generation antipsychotics like Abilify or Risperidone are becoming first line, very well tolerated. The OCD can be treated with SSRIs or serotonergic agents. Sometimes TCAs are needed. And then thinking again about the on-label treatments for some of the associated rage attacks. Propranolol can be very helpful for anxiety when I said beta blockade, or alpha agonists like guanfacine. 10x can be very helpful to treat the impulsivity and ADHD that often are associated. And of course, we use our CBT and behavioral treatments. First line, there are some patients that don't need medication at all. And there's a nice review in Neurology from 2013 that I referenced. Let's see. So a case example of just how it's helpful to keep in mind these phenotypic diagnoses and these syndromes. A simple reassessment. I have a 65-year-old man that I'm working with who has Tourette. I identified the Tourette because he had multiple motor tics vocal tics in Spanish and English, He has moderate to severe IDD, compulsive circle drawing, but then also some multiple repeated motor tics and compulsions that was creating a safety risk for himself because some of his tics were self-injurious, and a risk to others because he would sometimes have a compulsion to harm his housemates. Minimally verbal, on clozapine for many years, ongoing compulsive aggressions. He also had a history of an SBO and an ileus. And I said, what's going on here? It's so careful clinical review. The only record I have was going back about 15 years, where he was treated with clozapine. Zyprexa prior to that never made any difference. He was on high-dose benzodiazepine, and I'm not sure why he was on Sinemet from an outside neurologist, clozapine, and then sertraline, very reasonable treatment for his OCD. So I said, what's happening in light of the limited benefit trial of a first-generation antipsychotic? I trialed Prolixin for motor tics at very low dose to avoid any. I was hoping to avoid metabolic side effects, but he had significant fatigue. I coordinated with his outside care provider. Nobody really knew when the Sinemet was started. We were able to discontinue it. It could contribute to aggression and activation. So we stopped that. He had no Parkinsonism with the Prolixin, no Parkinsonism with the risperidone. And his compulsions ended up very well stabilized on Risperdal, 3 milligrams once a day. SSRI and clozapine were successfully discontinued. He's on 2 instead of 4 medicines. Very slowly we can taper the benzo. But this is a potential case where his compulsions are still necessarily present. Tics are still present, but they're not interfering with life. They're not stopping him from from going to program which he enjoys, and they're not stopping and they're not creating risk for him to injure himself or his housemates. So just a simple reassessment, keeping in mind Tourette, or keeping in mind our syndromic diagnoses when they're available. I mentioned this. This is also a CME question. So. Dravet syndrome, Dr. Seth Keller has one of our wonderful colleagues gave a set of lectures about one of his patients with Dravet. Dravet is a severe epilepsy, most often identified in childhood, caused by an SCN1A or 2A sodium channel mutation. Identified often with refractory myoclonic seizures in the setting of fever, and then it later is accompanied with behavioral and mood dysregulation, which is why we'll see it in clinic. But the key and the reason I'm mentioning it is it's very useful to have this diagnosis, because we may, as psychiatric providers, want to use maybe a well-tolerated off-label treatment for OCD or mood stabilization, like Tegretol, if someone has bipolar disorder along with their Dravet. Any sodium channel agent like carbamazepine, which is specific to the question, the CME question, but oxcarbazepine, if we're prescribing AEDs, topiramate, dilantin, phenytoin, any of those can potentially make seizures much worse in Dravet syndrome. We don't want to precipitate status epilepticus. We don't want to dysregulate our patients. Knowing this can be really helpful. If you are a neurologist in the audience and you have a Dravet patient and you have a patient that's going to a new psychiatrist, you have the opportunity to potentially reach out to them, because maybe a lot of the psychiatrists out there who are working don't know what they don't know. This is an example of some of the medical complexity that we can see. We can informally solve this problem together now, as we work toward establishing a fundamental baseline level of confidence. Yes?
We have 10 minutes left, and we want
Sure.
to leave some time for questions.
Sure, yeah, I'm almost done here. Okay.
Thank you.
Great, thank you. So another example, I use the example of trisomy for medical complexity, just to keep in mind that, of course, all of us are going to be familiar with trisomy. There's a lovely photo I found of Chris Burke, the actor in the 90s, who did a lot to bring awareness of Down syndrome to the public. But the fact that chronic constipation, we do see Alzheimer's in patients with Down syndrome, but primarily the reason I mentioned the slide is to give an example of some of the behavioral phenotypes that we see in clinics. Someone will come for obsessions or for rigid fixed behaviors or for cognitive changes, and to just remember that all of these things go with Down syndrome. Cataract goes with Down syndrome. Macroglossia causing potential sleep apnea, which can have really significant behavioral and mood and mood presentations. So just that's why I mentioned that. Of course, we'll see patients with FRAGILEX, this CGG trinucleotide repeat on the X chromosome, most commonly in males. There's a wonderful South African photographer, Roger Ballen, who did a portrait of FRAGILEX twins. Autism in a third of those affected, we see them in clinic because of hyperactivity, inattention, impulsivity, and OCD, sometimes pretty significant aggressions associated. Managing anxiety is going to be the key, but knowing our syndromes can be really helpful. We can teach each other about these problems because of the potential for FRAGILEX associated ataxia syndrome, the increased prevalence, depending on the number of repeats you can have, of cognitive change in early cognitive changes, and of Parkinsonism. So that can help us decide on an agent maybe that might be more like an SSRI, and GABA A agents are going to be the primary tools before reaching for an antipsychotic. But if SGAs are needed, then we can use them. But to have that special consideration, also just knowing, we use the example of Prader-Willi. So knowing our syndromes can be really helpful, and teaching our colleagues who may not be familiar with Prader-Willi before they start medications about them. So of course, Prader-Willi, if it's paternally inherited, is most commonly seen as Prader-Willi. It's sister syndrome. We're not going to talk about Angelman's, but the key is going to be the lack of satiety because of hypothalamic dysfunction will lead to hyperphagia and obesity. So we see the food seeking and OCD along with it, skin picking. We'll see them in clinic. I've had colleagues reach for something that may lead to a significant increase in appetite, which can be working against improvement inadvertently. So anxiety management in this case is going to be just knowing our syndrome is going to be best with agents that aren't going to increase appetite and lead to weight gain. Rett syndrome I mentioned. I'll skip that because we're getting low on time. And of course, just the risk of diagnostic overshadowing in something like tuberous sclerosis, which we see very commonly and is underdiagnosed as well. But in tuberous sclerosis, the reason I mention that is because of the risk of missing hydrocephalus and pain due to a hamartoma because of the when we may be seeing someone and attributing their worsened behavior or outbursts to autism or related disorders. So, and then last but not least, just knowing 22q11 syndrome, DiGeorge syndrome, very important that we're going to understand the multiple cardiac malformations, monitoring our QT. There is a clear link to bipolar disorder, but because of a concomitant co-located COMT mutation, these patients may be more likely to develop Parkinsonism. So that can help us decide on how to manage some of the OCD symptoms, or in the patients with concomitant bipolar disorder, can help us choose a mood stabilizer wisely. So the point is, together, team. There's an individual I work with, some Kriti Shah individuals that I wanted to include a photograph of. But the key is, where are we going to go in the future? In the future, together, we can make a difference. As I would just think, for now, the take-home message I would want is for you to be familiar. If you're a psychiatrist or a behavioral health clinician, hopefully you can use some of those resources going forward. Almost all of the references I included are reviews and should be free for download. There's those 2 books. Contact me with an email. But what I would hope is a take-home message of collaboration as being absolutely vital to being to a minimum standard of care for behavioral health care in individuals with IDD. In our career, I'm hopeful we can. In my career, I'm hopeful we can team up because of the lack of real inpatient care. I can't believe that behavioral units are allowed to have sometimes formal, in addition to informal, IQ cutoffs. I don't think that's compatible with the Americans with Disabilities Act. I'm hopeful we can ban that in our lifetimes. And I'm also really having a difficult time. We do see catatonia. We see malignant or agitated catatonia, especially in patients like with Phelan-McDermid syndrome. And getting ECT in many parts of the country, especially in New York State, is an enormous challenge with individuals with IDD. As controversial as it is, it's potentially life-saving. So hopefully we can solve that together. And I'm going to include my email. There's references that I hope can be useful for everyone. And please don't hesitate to contact me. This is, we're all starting on the ground together.
Thank you. Thank you very much. So we have several questions. I'd like to try to get to as many as we can. The first question is, a psychiatric provider I work with discussed PTSD relative to the frequent loss of important people in life relative to DSP turnover and the trauma from this. What are your thoughts on this?
Oh, I think that's. I mean, we saw this. That's a great point, and I'm so glad that that you're aware of that and that it's respected. I hope that you can share that message, because we saw that so much in the time of COVID. If there was ever a time where people mourned the loss of being able to be with loved ones, it was during COVID, when our DSPs were getting sick, were heroically caring for individuals, putting themselves at risk. So we saw the loss of DSPs. We saw loss of services, and to me, the treatments for these are going to be primarily non-pharmacologic. But I want to just offer respect and appreciation for your observation of the reality of that problem. So it's one more thing to add to the list, and I should have mentioned it in the talk. Thank you so much for bringing it up.
Thank you. This next question is actually from me. As a primary care provider, we're seeing the other side of the diagnostic overshadowing that you're talking about. And I have often been in the position where I'm asked to diagnose a UTI in a person who's having behaviors. Unfortunately, we also have a high incidence of individuals who have chronic bacteria, which may or may not have anything to do with their behavior. And the urologists are pushing us on the other side to not overtreat this, because we end up with patients with bacterial resistance. So can you help us in the middle navigate that?
Absolutely. I mean, I struggle with that as well, because in patients with indwelling catheters, that becomes a real conundrum. And then when patients have Foley's, or I don't want to treat something or risk making urinary retention worse with an anticholinergic medication at the same time as it's difficult sometimes to figure out. The only answer I have so far is that I make a lot of calls to urologists and to primary care doctors, so we can figure it out together. There's one individual that I don't have a great solution for, because she ends up very aggressive, creating safety risks, and irritated and delirious whenever she gets a UTI, and she's brought to both me and the primary care doctor and the urologist. And we sort of, punt to each other. I want to avoid using medications, but there is potentially some value in PRNs. While it doesn't shorten the duration of delirium, it can decrease the severity and can help an individual potentially feel more comfortable. Although, of course, the goal is not to sedate. So, I mean, in these cases, we do end up relying on PRN medications, or a short course of things off-label like benzo, although it's not ideal in figuring these things out. But these are some of the challenges that really require meetings and sometimes repeated conversations to decide how best to manage. And I don't have a great answer for that, but I agree that it is a problem. I'm not aware of a protocol to help work that out, aside from collaborative care and careful decision-making.
Thank you. We've certainly tried to do that in as much as we can. This question comes from Teresa Belair. Oftentimes, our individuals that present to the ER in crisis end up having their long-term maintenance medications changed, and then are discharged and they decompensate. Any suggestions on how to prevent this from happening, the hospital never consults with a treating physician.
Yeah, I encounter this quite frequently. You know, I just experienced this last week when someone declared themselves. You know, they have Lennox-Gastaut and atonic seizures, and they require a helmet. And I am so convinced that the helmet led to their repeated discharge from multiple emergency rooms. But they were in the emergency room 4 times in 4 days, and I didn't hear about it until I got back to clinic. Right away, I started, called and worked it out with the staff, and they did require inpatient care. I sent them in to an emergency room, called, and the emergency room team declined to let me speak to the consulting psychiatrist. The consulting psychiatrist changed a couple medications with some suggestions to me, and sent the person home when I feel they needed inpatient treatment. But again, this is a real challenge in our field: the need for inpatient and lack of competent inpatient care. The solution I have to that is actually, unfortunately, at this point, piecemeal. I provide education to the teams and agencies that I'm working with. If somebody's going to the emergency room, let me know. If somebody is having their medications changed by an outside provider, let me know. We can't, or how should I'm going to put it this way. It's assumed by people outside of the medical field very commonly that we all know what each other are doing. It's really surprising for a lot of non-medical staff to learn how opaque our different systems are to each other. So providing education that to the team and staff, that if somebody goes to the emergency room for a behavioral health issue, let me know right away. If somebody has their medications changed, let me know right away. And if somebody is hospitalized even for a medical admission, I ask to know right away, and I ask for a discharge summary for the same reason. The only solution I have is communication with the care team. So, if somebody changes if somebody goes to an emergency room and their medications are changed drastically, you can let their community provider know, and maybe, hopefully, see them within a day or two, which is what I try to do as well. But I agree, it's a real problem, and it certainly puts a chip on my shoulder.
Thank you very much. We are out of time. There are a few other questions in the chat box. So I will suggest that we take advantage of your generous offer to use your email.
Please do. Yeah. Oh, these are great questions. I'm sorry we didn't have time to get to them. Yeah, sorry. AIMS at least every 6 months, PRN, and then there's a video AIMS that you can do, although of course in person is best. Let's see, what else? Oh, great. Yeah, I hope I can help. And thank you so much for the opportunity. I'm so glad we were able to open this dialogue. That's great.
Thank you so much for speaking with us.